All right. Thank you, everyone. So we are really happy that you were able to join us on this day. I know we typically meet on the second Wednesday of the month and had to make a shift for January. So thank you for joining us. And today, our speaker is one of our hub members, Dr. Evan Holloway. He is a UCSF Department of Psychiatry assistant professor and licensed clinical psychologist. Dr. Holloway is attending psychologist in the Wavefront Outpatient Cognitive Behavioral Therapy Clinic at the Nancy Friend Pritzker building on the UCSF Mission Bay campus. He has advanced training in pediatric and forensic psychology, substance use disorders treatment, including motivational interviewing and family checkup, and services research. Dr. Holloway provides clinical supervision through the Multicultural Clinical Training Program at the Zuckerberg San Francisco General Hospital and research supervision through the Clinical Psychology Training Program and Juvenile Justice Behavioral Health Lab. His research focuses on improving behavioral health and legal outcomes for youth and families involved in the legal and foster care systems and service access for publicly insured youth. So with that, I will turn it over to Dr. Holloway. So again, he'll give us a brief talk here for about 20-25 minutes. We'll save time for questions. And then the second half of our hour, we will jump into a case-based learning. So also be kind of thinking about, do you have any students or cases that this topic is resonating with that you'd like some brainstorming with for the group? And we'll ask for volunteers right around the turn of the hour. All right, Dr. Holloway, take us away.
Thanks so much, Dr. Hack and Dr. Brewitt. It's nice to see everybody. As was just said, my talk today is going to be on substance use in schools, and I'm trying to be more artistic. And so I tried to find a school kind of theme here. I try to make it as readable as possible, but I thought it might be kind of cute to try. So bear with me. Thank you. Oh, we already did mindfulness. So disclosures. So no one involved in the planning or presentation of this activity has any relevant financial relationships with a commercial interest to disclose. We are supported by federal and state grant funding, both the Health Resources and Services Administration, the Department of Health and Human Services, as well as the California Department of Healthcare Services. Okay. So the learning objectives for today are to identify 2 pros and 2 cons to implementing substance use screening in your practice and school. Understand the screening, brief intervention, and referral to treatment model. We'll refer to that as SBIRT. And finally, to identify 1 substance use screener that could be integrated into an SBIRT practice at your school. All right, so I'm hoping to get started, kind of get the creative juices flowing and to hear from you all. I consider, when I say I'm here to give this talk, and yes, I have training, we all do, and I really consider y'all to be the experts in where you work and the clients that you work with. And so don't be shy about jumping in. So I'd like to first ask, what's the difference between kind of normal substance use and pathological substance use for children and adolescents? And would love to hear the way you all might think about it or what that distinction might be. So please feel free to unmute yourself. And if you can't, feel free to throw it in the chat. So what's the difference between a more normal substance use for children and adolescents and pathological? So there's no real wrong answer here. Just want to hear what y'all think.
I can chime in. Pathological feels like a very strong word, but I guess I would say normal would be like, if it's a special event or a field trip or something like using at school, but like the regularity, like if it's daily happening at school, that I don't know if I want to say pathological, but
Yeah.
that would be the more extreme where I would be very concerned if it's like super regular.
Okay. So if it's happening at school, but maybe it might be kind of normative depending on like a special event or something that's happening to have a sip of something with a family or to celebrate, depending on sometimes cultural practices or things like that as well.
Yeah.
Okay, great. And I'm just reading some of what's in the chat. Normal, Julie, normal is RX. What do you mean by RX?
Prescribed.
For prescribed. Okay, gotcha. And then pathological would be addiction. Okay, Patty using routinely. Okay, so we're talking about the frequency of when this might be happening. And then Sherry, you said illicit substance polydrug use. So using multiple types of substances that are illicit or illegal would be one way to think about if it, this is more problematic, would probably be the better way to frame that. Emma, thank you. Awesome. Okay, thanks everybody. I have one other question to follow up to that. Where you all work or just your sort of personal opinions, what are the biggest barriers you see to addressing substance use with kids and adolescents, especially in a school setting? Holly said, we've lost all the prevention and early intervention resources we used to have. Holly, could you speak to some of those resources that you used to have?
Sure. Yeah. Just like we used to have some people from Tupe, like who would be at multiple schools, but would be able to come and do like education around like drug education in more of like a tier 1 way, but also like counseling for students that were referred. And that's like disappeared.
Okay, thank you.
And
So
there's nothing in its place. Yeah.
got you. So some kind of primary prevention, maybe about substance use, having folks come in, and then also like actual providers who accessibility of providers for sure. Thank you. Stigma is definitely a big barrier. Follow up with parents. Would love to hear. We're going to talk a lot about involving parents and families. Patty, when you mean follow up, like, can you tell us a little more?
Just having the parents, actually, I wanted to say a little more, but I just kind of left it broad, but just like having them kind of admit to the fact that they are actually using. So that's a big thing. It's a big problem that we're having. Like we see it, but the parent just does not see it at all and refuses to see it. So that's kind of what I was getting at.
Gotcha. So like parents maybe like some denial or like, oh, this isn't, that's not really happening. And okay, thank you. Okay, and that aligns with what Sherry said. Maricela, parent buy-in in school boards, stigmatizing prevention strategies. Yes, so there can be some political influence, right? And maybe what resources are available or how to respond. And I see Emma, you raised your hand.
I think like overall our culture still really is very punitive. So like it's very hard to, especially as a principal, to sort of be like, hey, I'm worried about you. I feel like something's happening. Like the student will often deny. Same, I think, with parents, because they're afraid that that means you're going to be expelled, that you're going to get in trouble, that instead of like, no, just tell me the truth so we can get you the support you need. So it's like very hard to get the like, I'm coming from the like support caring side, not just punitive, you're in trouble, you're going to get kicked out.
Absolutely. Thank you. And some of that is because of the broader society we're kind of embedded within, right? And ways that behavior can be punished, behavioral health needs might be punished within school settings. So that is very, very important. Thank you for highlighting that. And then Katie, time to incorporate info in the curriculum. Absolutely. We're going to talk about one way to help address kind of like the more preventive and early intervention side today with SBIRT, but with any sort of prevention or intervention model, finding the time and resources is really key, right? To setting, addressing substance use, setting up a program for success. So thanks, y'all. Okay. That was super helpful. And I love the participation. Okay, so I think one of the big questions, a lot of what we were talking about was I was hearing a lot of like reaction, right? We have suspected there is substance use, there is identified substance use, perhaps. We know there's a need, and that might happen after, someone's high at school, or you find a substance, or things of that nature, sort of a more reactive. And so today I want to talk a lot about screening as one way to help bolster that sort of prevention and early intervention that y'all have mentioned would be really helpful. So this comes from a paper of US pediatricians, a national sample, who looked at implementing this SBIRT model, this screening and then brief intervention and referral to treatment. And so these were some of the main barriers identified in this survey that sort of get in the way of implementing screening and getting people into treatment, getting kids into treatment. Confidentiality issues are one of the most common reasons why this can be a challenge. Another one, this is something someone mentioned, right, is insufficient time. So finding time during appointments to address substance use, to talk about it. Where do you build that into your workflow in the clinic? A lack of expertise. So this is self-reported expertise, right, and managing substance use within your practice. So this might mean, so about 40% of people said they didn't really feel fully equipped to address substance use. And then about a third reported that they felt like there was a lack of expertise in managing substance use in the community. So speaking more to the types of resources that would be available, places to refer kids who could benefit from treatment, for example. And then a third of respondents also said there's limited opportunity to talk without a parent present. And so I'm curious, as we're thinking about how this might be implemented in practice, a more standard outpatient PCP visit versus what it might look like in a school-based health center. I don't work in that setting. I'm hoping to shadow some soon, but just welcome you all to think about logistically how this might work. All right, so I'm going to give a kind of a high-level overview of SBIRT, and then we'll jump into each of these specifics, do a little role play, and then talk about implementation after that. So screening. A best practice is to have universal screening. And so, and again, we're going to talk about best practices and what the research says, and then also, but I want you all to be thinking about, as you are already, what is realistic, what's possible, right? And so it's best to have universal screening for every child or every person within a target population. And there is some literature about opting in versus opting out to that screening. And so if you have it as a universal thing, you offer to everyone, you sort of normalize it, standardize it, but you give students the opportunity to say, well, I don't actually want to participate in that. That's kind of a best practice to screen as many people as possible. If it's like, hey, do you want to do this screener? They're, speaking to stigma, that can be a barrier to kids screening, right? Like, well, I don't want to take this screening because that's going to signal something about me, right? That I use drugs or something like that. So universal opt-out strategy, something that is standardized, whatever process that is. And I'm not a primary care provider, but I was learning more about the types of screeners that might already be incorporated into visits. So things like the HEADS or the SHADE screeners. HEADS meaning, and I'm not as familiar, but the assessing home, education, activities, and then within that, drugs, sex, and suicide assessment. And then I think the SHADE is a little bit more developed. Are those screeners familiar to anybody here? Okay. Okay. So we can include a link to that when we send this out if people are interested as like just broad kind of risk areas to measure. And then there are more specific substance use screeners. So the screening to brief intervention, S2BI, and the CRAFT, which we're going to focus on today, those two. Okay, so after screening, if a student screens positive, right, or based on the results of that standardized screening, we want to learn a little bit more about what might be going on and to see and to do a brief intervention. So brief intervention relies on motivational interviewing principles broadly. Those include, and this could be like a whole semester on motivational interviewing, but broadly, motivational interviewing, some core skills include using open-ended questions versus close-ended questions. So like, how often, or not saying like, do you smoke weed, for example, right? But how do you think about substance use? Things like that. Affirmations, so affirming whatever someone is telling you, as to the extent possible. Reflections. And so this can be as simple as literally taking what they're saying and responding back to them so that they feel heard. And then summarizing, right? And so hearing what a student might be telling you, trying to put it all together, and that's a different kind of form of reflection, telling them telling them what you heard to kind of make sure that you got it right. And then if a student is interested, right, you've identified that there might be a need, you've learned more about their motivations for using substances versus not, maybe changing their substance use, or reducing risk around substance use. It's important that it be aligned with something that they're interested in, or something that they might be interested in changing. And the next step would be referral to treatment. And so some considerations for that last step are, is this a more normative kind of substance use or more problematic substance use? What is, and how does that align with other presenting problems that we might be identifying? So should this be, is this something like that could be addressed in treatment, that co-occurring anxiety, for example, or are we talking about like something that is really causing a lot of impairment and might require a higher level of care? Excuse me. So two screeners that I'd like to highlight here today are the screening to brief intervention, or S2BI. And these are both free. They are available at this link below, provided by the National Institute on Drug Abuse. So S2BI assesses common substances, the most common substances for children and adolescents: alcohol, cannabis, and tobacco. One way you could use these two is that if somebody screens has like moderate or high risk on the S2BI, you could do a more in-depth assessment with the CRAFT. You also could skip the S2BI and jump straight into the CRAFT. And so CRAFT assesses more common substances, and as well as the level of danger or risk associated with those. And so we're going to jump more into those in a second. Okay. So the CRAFT is a 6-question. There's really several questions you want to follow up on, but broadly there's a score of 0 to 6. And so this gives an idea of the probability of a substance use disorder by the CRAFT score. And so the cutoff of 2, so if you're using the CRAFT and there's a score of 2 or more, that signals that there might be a likelihood of a substance use disorder, and you should do more in-depth assessment and assess impairment and risk and things like that. And as the score goes up, the likelihood of a substance use disorder increases. Okay, so after screening, there's brief kind of motivational interviewing. I talked about the OERS skills, open-ended questions, affirmations, reflections, and summaries. This is, and you will have access to all of these resources afterwards. I just did a screenshot. This is from the Massachusetts school-based SBIRT project. And one of the resources that they provided is, okay, what do you do after you get the screening results? And so I'll draw your attention to the left. And says that, so if there is no use, right, you still want to respond and talk about what those results are. So it's a good idea to reinforce that they're not using, to use reflections and or affirmations to reinforce those reasons, to educate. And so you can elicit what they already know about the risks of some substances, and if with their permission, to share some information with them to make more informed decisions about their use in the future. With their permission, you could provide some of those risks and then elicit again, what are your thoughts about that? Another way is to get them thinking about the future, what might change certain situations, or if there's opportunities, right, where they might be offered substances. Kind of summarize that quickly. And again, you want to reinforce that they disclosed. Now, if there is a positive screen, then this is kind of a guide that can be used to provide this brief intervention. So first, important to build some rapport, and then explore the pros and cons. What do you like about eating, edibles? What do you like less about eating edibles, for example? You can use the actual results from the craft to reflect back to them what they said, and then kind of provide that balance of like, on the one hand, here's some pros, here's some cons, and where does that leave you? Providing feedback using the same elicit, provide, and elicit strategy. And then I really like readiness rulers. And so you could ask, like, on a scale of 1 to 10, how ready are you to change any aspect of your edible use, for example? And let's say they're like, I'm a 4. Okay, well, why did you choose a 4 and not a lower number like a 3, right? And then basically reflecting back to them their reasons that they're providing. There's, this is a skill that you can keep practicing, but if you aren't sure what to say with the reflection, you can literally reply back almost verbatim what they said. That'll do too. And then finally, negotiate an action plan. What are we going to do next? And use the results from the readiness ruler to kind of think about if they want to make some changes or not. Okay, so let's say we get to a point where we are trying to decide if we need to refer for treatment. So here are some considerations. First action is you might do nothing, right? So if substance use seems fairly normative, there's no identified kind of risks or impairment, and it's a low clinical priority relative to other behavioral health or physical health needs, do nothing. If, let's say, there is some use and there might be a little bit of impairment, you're not really sure, right? You can give a little bit of brief advice with permission about ways to stay safe, developmental, considerations like brain development, body development, different, and identifying areas where there could be more risky use in the future. If it's kind of determined that this person might need outpatient or might benefit from outpatient treatment, you might make that decision if you realize, well, this could be normative, maybe not, I'm not really sure. There could be some risk, or yes, we have identified some risk and it seems like there is some impairment, right? Like they're showing up high at school, or getting in trouble based on their substance use, and you deem that this is a clinical priority, then an outpatient treatment would be indicated here. Next step up is intensive outpatient, and this should be really considered if it's not normative substance use, there's potentially life-threatening risk, there is significant impairment, and it's a clinical priority. And inpatient, really the same criteria, it's just there's a higher level of potential medical need, and you don't feel assured that this situation can be managed safely in the community or in your school. And there's a lot more of this, the ASAM, the Association of Substance Abuse and Medicine, I believe, in the link below, but this is kind of gleaned from that resource. Let's talk about what some of those treatments might be, and these are really focused on community-based strategies, not the kind of the higher level of care, keeping in mind that we always want to think about the lowest level of intensity of services and keeping kids at home and in their community. So some well-established standalone interventions include family-based therapy, CBT, multi-component psychosocial therapy, so things like multidimensional family therapy, for example. Some probably efficacious standalone interventions are motivational interviewing, motivational enhancement therapy, and some third-wave CBT interventions. 12-step programs are possibly efficacious, less so than the others that I've mentioned, but some people do benefit from those interventions. And then I list below some other types of interventions that could be helpful that aren't necessarily, they're not really standalone interventions, but can be adjunctive. And then finally, there's more and more research looking at digital strategies as ways to sort of support substance use management and risk. Okay, and this comes from the link below as well. All right, how am I doing on time?
If you could wrap up in like 5 minutes, that would be great, Evan.
Okay, cool. So then what I'll do is I'm just going to kind of model this really quickly, what that process is. Yes, Sherry, go ahead.
So I've used the craft on kids that have come into the school nurse's office.
Mhm.
I think the most difficult one is I have fourth and fifth graders, and And the C part B, C. Have you ever ridden in a car with somebody? Obviously, they say yes, and it's their parents. How? I need some tips on how to deal with that.
That is tricky.
Good. Yeah, it is.
Yeah, that's really hard. And I welcome anybody else who has faced this situation as well. I would say first, it's great that they disclosed. It means that you have established some rapport and they trust you and you're doing it in a non-judgmental way. I can't say specifically what you should do based on what you learn next, but it's really important to kind of assess what risk is and to just learn more about how often this might be happening. And before going kind of moving forward, I'm curious if other people have any ideas or if you face the situation as well. And Sherry, maybe one thing you were hinting at is one thing that's coming to mind is what do you do with that information in terms of would there be a need to
Yeah,
report that?
exactly. So I've had a couple kids answer it, and I'm, out in the country. I think the closest town's like 20 minutes, but so there aren't like really any community resources. And I think what I've said to them is, wow, that must have been very scary. Or, I've tried to reflect without, now of course that's in a way of judgments, One kid said, yeah, it was. But the other ones, they just kind of, don't say much. So I just, if you have, maybe how to respond to that, or, so just some hints. I guess that's all I'm looking for.
Well, I think what you said is the best thing to do is to reflect back to them and to try to elicit more, right? Hearing them telling you more about that. And then based on what they give you, this is a clinical judgment call. So I can't tell you exactly what to do within your practice, but I would say there is always a risk of the more that you ask, the more you're going to learn, right? And so I think if you learn about risk, you don't want to ignore that, obviously. And at the same time, I think this just speaks to the importance of informed consent in all practices so that you let them know what those limits are, what you might have to do. And if you learn something like that, to remind them about what that is, right? Not in a way that's going to shut them down or shame them, but I like to orient them back to your safety is my number one priority, right? That's personally how I do it. I'm curious if others have any tips on that or ways that they might manage that.
Yeah, or like if things come up that make me worried about your health or your safety, we're going to need to find a way to talk with somebody else who can help support you, which might be your parents or whoever's relevant for this young person.
Yeah, thanks, Lindsay.
I've had this too, Sherry. It's so tricky. I feel like with 4th and 5th graders, it can be hard to tease apart. Like they might be more black and white about like somebody's having really a tiny bit of substance use that maybe wouldn't be problematic in the eyes of the law versus heavy substance use. It